So, good evening and a warm welcome to all the dignitaries present here. I'm Shreyoshi from Clanet, serving as the allocated session assistant to ensure a seamless experience. Clanet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clanet serves as the digital partner for this event, hosted by the Indian Association of Preventive and Social Medicine. And the focus of today's session is weaving narratives and stimulating realities in primary healthcare teaching learning. So let's begin today's session, for which I would like to invite Dr. Animesh Jan sir to take over. Over to you, sir. You can proceed with the talk now.
Thank you, Shreyasi, and thank you, Clarnet. So here we are again with another edition of the IAPP webinars. IAPP is for Intercollegiate Academic Program for Postgraduate, which started much before COVID times, and it was a physical in-person meeting. It used to be in a small region of Dakshin Kannada in Karnataka, but then over the period of time, as technology has provided us this platform and Clarnet is a partner, we have taken it upon us to reach out to more people and far and wide. This also helps us to come with different topics and get experts from different places. And this, in a way, is also a good outreach for people who are finding it difficult to actually come and attend it in person. So with today's session being planned, I'll come to that in a bit, but then we have Dr. Poonam Nayak, the president of IAPS in Karnataka state chapter, as well as we have Dr. Asha with us, who's the vice president along with me as the vice president for the IAPS in Karnataka chapter. So I'll request Dr. Poonam to give her opening remarks.
Yeah, thank you, Dr. Animesh, and a very good evening to one and all, and welcome to one more session of IPP. I also welcome Dr. Sudhir Prabhu and thank him on behalf of IPSM Karnataka chapter for having accepting our invite. So I'm sure more participants would be joining eventually. And this is also a very interesting topic that we have by Dr. Sudhir Prabhu today, the weaving narratives and simulating realities in primary healthcare teaching and learning. I'm sure this was going to a different topic and would be of interest to the participants and the audience over here. So let us move forward with this. Thank you. And thank you, Dr. Sudhir Prabhu. Thank you, Dr. Animesh.
Yeah. Thank you, Dr. Poonam. So before I begin the official talk before we begin the official talk by Dr. Sudhir Prabhu, it's my pleasure to introduce him to the audience. So Dr. Sudhir Prabhu currently serves as the professor and head of the Department of Community Medicine at Father Muller Medical College at Mangalore. And he has worked as a medical officer for people living with HIV, the patients at JJMMC Davangere, and also at rural and urban health centers of Father Muller Medical College at Mangalore. He is graduated from Kasturba Medical College, Mangalore, and he has done his PG in community medicine, MD in community medicine from JJMMC Davangere. Currently, he is also a national trainer for the TVAC course and effective vaccine management assessment for Ministry of Health and Family Welfare. He is the member secretary for a particular association, which is a very progressive association, Association of Public Health Technologists. He is a member of Campaign Digitization Working Group of Health Campaign Effectiveness Coalition of the Task Force for Global Health and member of the Delphi Consortium, Essential Research Skills Training Consortium for the Global Health Network, Oxford and WHO TDR. And he is editorial board member for 2 journals, peer reviewer for 22 national and international journals. He has more than 10 funded research projects and clinical trials that he has been a party to. And he has also authored 50 publications, 10 textbook chapters, and 5 advocacy reports and policy briefs, which he has been instrumental in. He is the chairperson of Serious Adverse Events Committee and member scientific committee, deputy chairperson of the NITTE Central Ethics Committee, and member of Institutional Ethics Committee at KMC Mangalore. So with a brief introduction, I am very happy and pleased to present to you Dr. Sudhir Prabhu, who's going to talk about one of the things that he's passionate about, that is weaving narratives and simulating realities in teaching and learning of primary healthcare. So over to you, Dr. Sudhir.
Thank you so much, Anime sir, for the introduction. Thank you to the office bearers of IAPSM Karnataka State Chapter, Punam ma'am, Anime sir, Dr. Asha, and all the audience. I would like to thank Animesh Jain sir for giving me the opportunity to interact with you all today. Without waiting much of a time, I'll just start with the topic per se. Is my screen visible, sir?
It is visible. It is visible.
Thank you, sir. So, right. So this is what I wanted to talk to all the postgraduates and young faculty members about weaving narratives and using simulation in primary healthcare teaching and learning, what we have been implementing in our institution. These are my disclosures. Right, coming to the session of objectives, by the end of this session, I think you should be able to understand the principles and applications of digital storytelling. I'm sure many of you may be familiar, but those who are not familiar, I'll just run through what is this digital storytelling and how it can be made impactful in community medicine teaching learning principles. Explore use of communication simulators. Communication is a very important tool for primary healthcare and community medicine, no doubt. So how can we use this for interpersonal and professional skills? I think relevant for both postgraduates and undergraduate teaching learning. And a new concept I want you to understand with respect to higher order thinking, escape room methodologies, how we can teach emergency primary healthcare concepts using this new methodology. So I'll be running through few resources and practical steps, how we have implemented it. I'm quite sure once I'm quite confident rather that once I'm able to take you through this, what we have done, you'll be able to do even better or refine it. Now, coming to community medicine and Indian medical graduate, I would like to give a disclaimer here. I'm not an MEU person, but considering what has happened over a period of time regarding the competency-based medical education and UG medical education regulations, I think this has not changed much, but the curriculum hours and thing has remained the same. Expectations from community medicine department for the final end product of Indian medical graduate is consistently high. And this is something which I debate with my MEU colleagues from different departments whenever I attend an MEU event, that do we really address through other specialties the primary healthcare components, relevance about what exactly is primary healthcare, about essential medicines, how it should be delivered, the grassroots level physician, and aware about all national health programs. Is it happening in other subjects? And to be honest, over the period of time, the importance which is given to our subject, are we justifying it? Or are other subjects trying to integrate and trying to understand what is actually needed from their subject to bring in this Indian medical graduate? So, as I told you, during over the phase of the curriculum, right from first MBBS till internship, community medicine has been given a lot of importance. But I'm sure most of the faculty here will agree. This is one of the reasons why students dislike, I won't say hate, but they tend to ignore the subject, and as well as take it as a burdensome subject because it's there throughout. The faculty, they need to see over and over and again. Now, just talking about need assessments, this is something which I felt, the felt needs which NMC is expecting from us through Health and Family Welfare or Department of Medical Education, to bring in an Indian medical graduate who is well aware with primary healthcare for the community and providing medical and healthcare to the community he serves. But somewhere I'm sure all of you will agree with me that there is a dissociation, there is a gap which we as faculty, as future faculty, because we are addressing postgraduates in this session, it gets dissociated between what is expected to be taught. I'm not talking pertaining to one or two subjects. I'm talking specifically with respect to the curriculum as a whole. And if we think community medicine is one of the important subjects which should be bridging this, we need to look into newer methods or newer tools which we need to bring into the teaching learning domain so that this gap can be bridged. Now, I'm sure there are a lot of constraints and barriers. This is what I have listed out. Again, it's a disclaimer. This is what I felt it in our institution also, in other institutions also, mainly pertaining to lack of adequate resources. I'm sure when you plan your FAP program, irrespective of whether you are in a public, in a government institution or a private institution, or one subject where there is a consistent lack of uniformity between what is taught in community medicine curriculum. Although NMC lays down the guidelines, some institutions, when they teach community medicine, it's predominantly focusing more on research. Some focus mainly on primary healthcare, or some may be talking with respect to newer methods or bringing in newer innovation tools. This doesn't happen with the other subjects. Most of the time, even in postgraduate teaching, we see a lot of diversity when it comes to community medicine as a subject, which is normally identified from where have you done it. And the entire structure of what PGs have learned will be totally different. And obviously, that is what we pass on to our undergraduates also. And one of the most important reasons I felt, especially more so in private medical colleges, not a revenue generating department. So most of the time, resources, especially newer innovative tools to get, to procure, and to convince the management that this is how we need to implement or we are planning to implement, becomes difficult. Right. So what is digital storytelling? It's a practice of using digital multimedia tools to create and share compelling narratives. So we are all aware that whenever we start a class, especially the set induction part, we normally start with a story, and many of us are good with it. And many a times students love classes which start with storytelling, or it is near to reality. Now, one important difference, what I felt is when we are storytelling in community medicine in the classrooms, students are left to imagination, because in other departments, especially the hospital side departments, they generally tend to narrate it with some cases or some patients who are coming to the OPD or some who are there in the ward. And in community medicine, they are just imagining all the time. And the smaller aspects, especially the social issues, the economic issues, emotional issues, are generally left unaddressed. And the sad part is, even in clinical subjects, these components, which are very, very important, which our Indian medical graduates should know, is left untold. Okay, and an additional issue is our faculty, even postgraduates, are very active now in the field, being in so many programs. We have more than 26 national programs, and most of you would be involved in one or the other way with government health, public health departments, or at state level, district level at least. You'll have a rich field experience, but unfortunately, somehow it doesn't translate when we are teaching it to our undergraduates or postgraduates. Now, this can be bridged, or let me say this, we have tried to bridge through our digital storytelling initiative, with main emphasis that the students can learn empathy. They know what exactly is expected out of them when they are there in the community or in the primary health center, providing healthcare to the needy. Now, how do we implement this? So before implementing, what are some of the key story narratives which we try to share with students, which are not so commonly taught in clinical subjects, especially, let's say, a patient journey narrative. A poor patient who has been diagnosed with cancer, how he had to go through multiple health institutions, referral points, how much economic burden it had on him, what are the consequences to the family. Okay, similarly, public health issues which are not taught as in problem solving exercises, or practical problems, like, for example, something relating to outbreaks. Okay, health campaign stories like polio eradication initiatives, community health worker experiences when he or she is trying to address a vocal vaccine denier. or vaccine hesitancy in the community. So there are a lot of tools available to create this. It's not very complicated. A lot of them are free. I'm sure most of you are aware about that, like Canva. There is this, I'll share next about the story map. If you want to bridge a link, especially through maps, then obviously, which most of us use, Google Slides, Microsoft PowerPoint, iMovie, Adobe Express. Now, what are the key components? What you need to do is bring in a compelling narrative, which is very strong, have relatable characters, which the UGs or PGs know. It can be the ASHA worker, which they have known, the same name you can bring in, or the patient which has come to the primary health center, or the clinico-social case which they have taken, or it can be simply the family which they have adopted in their family adoption program. That can be the character, and build a story around that. Okay. And once you have done that, you need to practice it, how you will be using the audiovisual aids. Okay. And most important thing in digital storytelling is practice storyboarding. That is, what component should come next. Okay. Sometimes you will be bringing your field experience, what has actually happened. Okay. But to bring in that extra emotional component, I'm not saying like a movie director make it totally left to imagination, but bring in that component which you think is relevant to bring in that strong emotional and engaging storytelling for the students, so that they are able to learn from that particular lesson objective, what is expected from them for that particular classroom. Okay. And keep it very short. It shouldn't be a story shouldn't be more than 3 pages, or more than if it's a video, not more than 5 to 6 minutes. Okay. And one important advantage is there are different types of learners. I'm sure all of you will know, some are visual learners, some like to hear and learn, some like to see, read again and again. So all this is possible when you are doing digital storytelling. And what we are planning to implement is bringing this digital storyboard into our LMS, learning management system, so that students can see again and again, and they can learn from it, practice it. Okay. And understand what is it relevant from respect to primary healthcare and community medicine. Now, difference between traditional and digital storytelling, I'll just give you few examples like how this impact can be seen. Now, for example, I'm sure all of you will start your story if it's relating to protein energy malnutrition, saying Raju or Ramu is a 4-year-old with protein energy malnutrition. Okay, just see the difference when you are bringing in a picture, a multimedia tool. Okay, and it is easy to build narrative around that with number of respiratory infection episodes. You create a family where there is overcrowding. There are a lot of children. Hygiene, overall environmental conditions are not good. Okay, so this probably a student may not be able to see sometimes in their adopted villages also. But once they finish their course and they are going as primary healthcare physicians, they might be in a better state to evaluate, especially to talk with respect to advocacy or any other healthcare routine changes. So that's the impact. Okay. Similarly, it's very easy to say a TB, HIV co-infected patients, and there are drug adherence issues. You create a story around it, but moment you bring in a picture, just let them reflect. See, this is a patient who is diagnosed with TB, HIV, and this is his pill load on a daily basis. Okay, that's the impact which one single picture will have, rather than just telling a patient has poor drug adherence because he's on multiple pills. The same thing can be created for polypharmacy when you're making the student build awareness in the community. Okay, so the students also will be able to build a story narrative, and they can obviously work with their research or do health education in whenever it is required in the community. This is something which I keep telling because this was my first experience as a postgraduate when we were doing an outbreak investigation, and it was a border district state between Karnataka and Andhra. So there was an outbreak of measles in fever with rash rather. So we went to the village and we were finding a lot of cases, and there was this child who was 9 months old and due for the measles vaccine tomorrow. The mother was telling no, he's not affected, and when we just turned the pinna, there was this post-auricular rash. Okay, so again, very strong message which we can convey through digital storytelling rather than just conventional storytelling. This we had tried last time when Dakshina Kannada had a lot of cases of dengue, and district management had asked us to build awareness in the general community. So we took pictures and build stories saying how these small bites can end up with fatalities, and the loved ones, family members, small children can die because of severe dengue. Yeah, this is what I was telling you about story map. Again, during COVID-19, we had one issue where one of our super specialty hospital was incriminated by local leaders, politicians, bureaucrats, and mainly the media, saying that was a hub for spread of COVID-19 in the city of Mangalore, and we were part of that investigation. Now, we created a narrative to make students understand how during pandemics and outbreaks, hospitals may be incriminated. So just creating a map narrative, okay, from the case, how it started in airport till, because we were border district area, so there was a lot of restrictions, especially going across borders, and also all these narratives we created on the map, right from the first case, incidence case, the local hub near one of the fish port, then airport, also the hospital and border areas. Okay, so students are supposed to reflect on what went wrong and what actually needs to be done, so that they can understand next time if it also happens, what they should be aware about, and as primary healthcare physicians, how they will be in a position to act to this outbreak scenarios in different clusters. How do we engage students? It's left to you, depending on the resources which students are comfortable, and institution has provided it across. So we have tried both with individual devices. Students were comfortable, okay, building up the stories, and they go through the stories and give their individual assessment at the end. And definitely you can use it as part of your SDL activities, the digital storytelling, and they love it, they like it a lot. Okay, but only constraint is time. So plan it accordingly, whether it's a 2-hour session, 3-hour session, so that you utilize the time appropriately. Similarly, we can do it for the entire classroom. I think many of you would have identified Dr. Sean Murphy from The Good Doctor. We use this digital storytelling as a reflection during AdCom session. We ask the students how they feel if Dr. Murphy was one of their peers when he gets a different privilege. Similarly, how would they respond if he was their treating doctor, okay, or as a student, okay? So they are supposed to reflect, and yeah, so we get wide perspectives from students, especially during this AdCom sessions. So that's about digital storytelling. Coming to communication simulators, communication also is very important. I'm sure all of you will agree. What we do is we create tool scenarios to mimic real life communication challenges, but it's in a safe and controlled environment. Okay, so one advantage is learners can refine it. They can practice again and again and again till they develop, and you can assess that they are now fit for that particular communication scenario. Okay, and there are a lot of examples on a lot of types of communication simulators which you can implement, and which we have implemented. One example which we were looking in is bringing in standardized patients. This is something which one of our faculty had planned for bringing in communication for LGBT, especially. This is something which we don't teach our students commonly, how to talk to patients who are from the LGBT community. So standardized patients are nothing but they are actors. They can be fellow colleagues at times, depending on, again, I told you resources, what is there. So if you are bringing in standard actors, the quality will be good, but you should be ready to invest, Okay, you have to pay them so that they are also willing to come whenever you want it. Okay, and make it very clear what sort of an interaction, especially if it's clinical history taking, especially sometimes very sensitive topics like sexual history, which we normally often don't expect students to take, nor we are interested to listen into. But it is very, very important when we are talking about diseases which are more common in vulnerable population like LGBT community. But we often tend to miss. So bring in this standardized patient concept. Similarly, it can be done with communication mannequins. Okay, now basic simple communication mannequin. I don't want to name the company, but it's wonderful. We recently had in our skill and simulation center. The basic mannequin starts with 50 to 60 lakhs. Okay, it's fun, and it has this AI inbuilt model where you start communicating, you start talking to the mannequin, it learns in your local language. So over a period of time, you can have this mannequin talking to you, conversing with you in Kannada, Konkani, Beri, Tulu, okay, all local languages. But I already told you the resources is something which you might be depending on the institution for. Uh, uh, yeah, safe environment is one of the most important advantages, which currently students have limitation when they go to their family adoption program, where families may not be that welcoming at times. Next, we have app-based simulations. I'll talk about this. Similarly, AI-based learning, where we can teach students about counseling. Now, it can be used for a lot of things, like how to break a bad news, okay, motivational interviewing, especially adolescents, conflict resolution, again, in adolescents, addressing vaccine hesitancy in parents, okay, and so many health education sessions. Now, these are the different methods which we had used. Okay, so one on the right hand side, what you can see is this is one of our associate professor who had built in this with the smart board itself. He had given the prompts for the student to interact. This was mainly counseling session for overcoming with drug abuse. Okay, so student was given the Kalamazoo checklist for communication, and based on that, the student was supposed to interact with the AI model here and counsel him how he or she can actually overcome through this substance abuse issue. Okay, so all the checklist, and there is a live interaction which keeps on happening, and student is given a real-time feedback. Similarly, here on the right-hand side, you can see this again during COVID-19. We had used this simulation game where the students would get. This was done for interns also. They get to decide triage and referral. Okay, especially which patient will go to the fever clinic, how will they communicate it to the next higher facility. Okay, and down we have this free software. Simulation software. Now, in our skill and simulation center, a lot of clinical faculties go there and feed the simulation scenarios, and there are a lot of high fidelity mannequins also, which will bleed, they'll sweat, pulse drops down, breath sounds will be disappearing. Okay, and unless intervened, okay, the student will be feeling that the patient has not recovered. Okay, so these are some of the interesting methods which are available now, and students feel much more interactive and happy to have this, and this is something which we need to also bring in primary healthcare scenarios. So last component for today, this is escape rooms. This is nothing but a gamification tool itself. It's interactive scenarios. Learners will get work together. It's like a buddy system. They'll get clues or puzzles, and the fun part is there is a stress component because there is a time limit. Okay, they have to finish it in 5 minutes or lesser than that. Okay, and only when they finish that clue, they'll be getting the next clue. Okay, so that is what is escaping from the scenario. It's not like they actually go out of the room. Okay, so they'll get a reward or they'll get to the next scenario. That's what is the meaning of escape rooms. So advantage of escape rooms is there is better student engagement. They love to do it because continuous there is involvement. No one can be left alone to sleep or do their own activities on the mobile phone. There is better critical thinking. Consistently, they are challenged, okay, because what they have learned, they have to apply it here. And one important thing is, because it's a buddy system, it strongly promotes teamwork. Okay, though we clearly give them that it is a team activity. So again, a very important component of primary healthcare, interprofessional communication and interdisciplinary also at times. So sometimes we also tell, although they are from MBBS or from different phases of MBBS, we tell them one is a doctor, one is a nurse, or one is a ward boy, something like that. Okay, and most of the time they love it. It's a memorable learning experience. Now, the best part about these three methods is they need not be in isolation. You can combine. Okay, it can be combined all the three together so that it is made even more fun. Right. These are some of the examples of escape rooms. I'll talk about triage, tag, puzzle, CPR sequence, because this we have implemented. Similarly, you can have this for medical calculation riddle, where let's say a child has been diagnosed with ARI. This can be given as a digital storytelling tool, and the student is supposed to calculate amoxicillin dose. Okay, based on whatever. Tell them this is the body weight, and they are supposed to calculate. Only when they are solving that with the application, okay, they'll be given, let's say, amox tablets, okay, or if you are calculating for dehydration, okay, you can give the key saying this is the pharmacy key, so that they have successfully completed the activity. Okay, so that is the whole point, that there is an end event which is escaping them, or it's like taking them away from that particular what to say, the theme or timed activity. Important point here is it looks fun, but requires a lot of planning. Okay, so time commitment, and sometimes if you are not doing it well, students may not at all be involved. Okay, that's the worst part. So be prepared and plan wisely so that all the budgetary requirements, infrastructure requirements, appropriate technology, you have it in hand. If not, try to incorporate with other departments, plan, collaborate, and then bring it. Okay, this is an example which I love implementing. I had implemented it, and we do this both for third MBBS students also, and we do this for interns. Okay, the outcome is the learning objectives are different, because we are expecting in third year mainly from a teaching perspective, but for interns we want them to understand and implement it in the urban and rural health training centers if there is a triage case which comes in. Okay, so you can plan accordingly whether you want it in the simulation center or you want it in the classroom. Both can be done. Just a instrument what I have given you, I normally tell that these are the, let's say, to make it as realistic as possible, we say there is a missile attack. Okay, this is recently because of ongoing warlike scenarios. Just say that you are at the site and or you got a call. There have been 6 mass casualty victims who are there at the site. How will you act at the community? Okay, or they have reached the primary health center. How will you segregate or how will you triage them? Okay, so they'll have to identify which color coded tag will go to which lady. There will be some emotional component, like for example, most of the time, moment you give a pregnant lady, most of the time they'll tend to get carried away, say, without looking at the vitals, 2 lives. Okay, so address those kind of issues. There will be conflict between the buddies. Okay, that's the part, but they'll have to act within that particular time and say this is the triage tag, and then they'll either escape the room or the session will continue. Okay, so the teaching learning technique for the when you are practicing it as a simulation scenario, especially for interns, this is what we do. So that should be pre-briefing and that should be a debriefing. Okay, so they should know whether what they have done, okay, whether it is right or something which they need to correct it for the next time. So there should be a debriefing, feedback for the learners, without which the activity is not complete. Now, as I told you, resources are very important. We were fortunate that during COVID time, I was able to get mannequins worth almost 4 lakhs from Doctors for You and Dr. Chetna from HCL, Tech Lead from HCL Foundation. And with the help of our SIM lab director, Dr. Lulu, and lab coordinator, Mr. Pradeep, okay, the Mulaj activities, what we do for TRAJ. And the same thing we follow for CPR sequence. And what happens during this escape room, that's what the learning domains, all cognitive, psychomotor, affective, they'll understand the protocols for TRAJ, how to classify, how to arrange referral from the field side, how to act fast, how to communicate, how to be a team leader and take the lead when there is a chaos like situation. Okay, not to be emotional, listen to incident commander. Okay, and best part is what we keep telling, higher order learning skills become very, very evident because they start applying what they have learned, and with the understanding that when it's not like this is the only training, they will definitely lead a lot of training. This also will make it very clear to them that TRAJ is not learned only once, but more and more they learn, they'll be able to better apply when it comes to a field scenario. Now, coming about all these tools, why this? I personally feel, this is my perception. So there may be faculty or postgraduates who differ. I think students love technology, and with use of better technology tools, there will be active learning, collaboration between the teacher learner. We'll be able to apply more and more real world applications, more so for primary healthcare teaching learning activities. And a lot of our SDL activities, that's the most important part now. More than, if I'm not wrong, more than 50 hours is for SDL over a period of 3 phases. And one important thing, what we also will get to learn is make it as realistic as possible for the learners. That's what they find it missing in community medicine. Okay, so bring in visual stories, videos, bring in some vital signs which they can also see, appreciate on the display, this thing like a BP monitor. Okay, and include outcomes. Like, for example, in simulation scenarios, it might be tricky at times because you don't want to give them a death count. Okay, you have killed 7 patients till now. That itself may create anxiety, but it's good. It's good that if you tell them that they were not able to revive the patient successfully. This especially during escape room when you're doing TRAJ or CPR sequence. Yeah, some practical tips. Start with small projects. This is how we did, not to include all 3. Okay, gradually increase to complex tasks. I still feel we can refine it better in our settings. Okay, take help of your colleagues or faculty from even different departments or simulation center. What you think can be done for community medicine and primary healthcare teaching learning in your institution, depending on the resources you have, depending on the skill sets and resources you think which can be given by the institution, and you can also implement it. Focus on specific learning objectives which align with the educational outcomes for the learners. That's very important. Lay down ground rules at the beginning itself. Okay, what is expected from them, and like, for example, many a times during TRAJ scenarios, I try to be not there, especially if it's a skill lab based scenarios, or if you are there, you tell them that you are the ambulance driver. You are waiting for them to give the instructions. Okay, when they are interacting, they shouldn't be seeing your face. It will happen, but give them that poker face, saying it's their call finally whom they want to transfer to the higher facility out of the 6 cases, or the TRAJ tag, what they have given to the cases. It is final. You are not gonna give feedback at that point of time. Okay. I've already told you, address ethical concerns, especially privacy, confidentiality. Especially simulation thing, you have to be very, very smart. You tell the student what happens in the simulation center stays in simulation center. They can't go outside and say he was not able to complete this task at all. He took 6 attempts. Okay, or I already told you, don't give them dead body counts, like you have killed 7 patients till now, you are killed 10 patients till now, you are useless. Nothing. Those kind of things should be totally avoided, especially a skill activity which is being taught in a simulated environment. Always peer feedback. This is something I think most of you from MU will be implementing, but those who don't know, we always ask 2 points: what went well and what needs to be improved. Okay, so this we ask the students first, and then we ask the peer who was there, the buddy along with the student, what according to him, what the student did well, what needs to be improved. Before the faculty gives the feedback, we take feedback from the student, then the feedback from the peer, and lastly the teacher gives the feedback. Okay, so benefits and application, I think that's what I have tried to make it clear. It's mainly for critical thinking, reflective learning, active learning, building communication skills, better retention, make it a memorable experience. That's the whole thing. And things which normally we don't teach in our subject, or even for that matter in other subjects which are relevant for primary healthcare, working as a team, okay, how they need to see social issues, economic issues, and other issues which are very important for a Indian medical graduate to address the healthcare needs of the community. So where all we can bring in, I already told you, it can be brought in SDL, ADCOM sessions for health education awareness, what they can create in family adoption program. If someone is implementing for especially for postgraduates, okay, directly observation or OSCE sessions, if your university is mandating it. Okay, so that's all from my side. If there are any questions, I'll be happy to answer.
Thank you, Sudhir.
Thank you, sir.
Yeah, thank you. You can. So if there are any questions, participants can put in the chat, or maybe you can even raise your hand and we'll unmute you. I don't see any questions in the chat. Neither do I see any hand raised. Anyone wants to say something? Anyone wants to? A nice presentation. I get one. Thank you. Somebody is appreciated. So Sudhir, thank you for giving us these insights. And it's nice to see that some of these things can be actually replicated. Yes, enriching experience. One more message has come. So I think it's very nice that we got some insight. As I understand, it will be much better understood if we try and experiment with some of these and then try to implement it, because experiencing it firsthand will give a different kind of a feel and a much richer experience. There is a question, Sudhir. Communication simulators. Please, can you tell us the company name?
Okay. So in our Father Muller Skill and Simulation Center, we had the NASCO one. He's named Alex. Okay, but once you purchase him, you can give your own name. You can call him Timmappa or B Fatima, whatever you want. Okay, and what main purpose you are planning to use this simulator for? And the best part is, as I told you, it can be used for multi purposes by multiple departments if you have a good skill lab. And only issue is cost. So I think very hard to get management to convince the management that we need a simulator for community medicine department, which the basic model costs around 40 to 50 lakhs.
Yes, but you can program it whichever way, and it's a very high fidelity simulator, so it really works. And you can program the history at the back. And so I had experienced that during the last Simedicon. Okay, Sudhir, you can, I think, stop sharing that screen. Still sharing the screen, so yeah. Okay. So I don't see any other question. I think really appreciate giving us some insights, and it was good to hear how we can in community medicine use simulation as well as the storytelling. And you talked about how do we build on that story, how it should not be too long, and you talked from your experience. So that was really nice. And I think I'm sure that the audience, whoever has attended, will be benefited. Let me also tell you that this will be archived and this will be put up on the YouTube channel of IAPSM Karnataka. That's a practice. We always do that. So every webinar actually gets finally uploaded on the YouTube channel of IAPSM Karnataka in a couple of days. Maybe we'll take 3-4 days. We'll get the recording and then we'll upload it. So that's what is done. And all those webinars which we've conducted in the last 2-3 years, we have always put it up. So it's also something that the audience, anyone wants to visit, they can go to IAPSM Karnataka YouTube channel and see any of the previous webinars as well. So there's another appreciation, really innovative and enriching, right?
Thank you, Dr. Sudhir. Both these teaching learning methods, they look promising, and definitely, as Dr. Animesh mentioned, people can definitely think of taking it forward in their institutes as well. Yes, maybe the cost component is one of the major challenges, but where the institutes usually look progressive, or they are progressive in nature, and they look forward for more of these innovative technologies, especially to keep up with the today's generation of the students that we have. So I think that would be really promising for them as well. Thank you for sharing your experiences.
Thank you so much. Thank you so much.
So I don't see any questions and there is no hand raised. In that case, I think, yeah, there is a link posted about the YouTube channel of Karnataka IAPSM in the chat box for the videos which are archived from previous webinars. Dr. Asha has done that. Thank you, Dr. Asha. In fact, Dr. Asha helps us with that archiving. So thank you. So I don't see any questions, and let's then conclude this. I think that's really nice, and we are well ahead of schedule. So thank you, Dr. Sudhir, once again, and thank you, Dr. Poonam and Dr. Asha, for being here, and all the audience. I thank Clearnet for partnering with us and providing us this platform, and Shreyasi for handling and moderating the initial part of the webinar. Over to you, Shreyasi.
Thank you, Dr. Animesh. Thank you, Dr. Asha.
Thank you to all the doctors for your valuable time and insightful talk on the topic today. And with all your permission, we are concluding the session here. Thank you for your time. Have a
Thank
great
you
day,
all.
everyone.
Thank you.
Yeah. Thank you so
you.
much.
Thank you.
I didn't know you were on a webinar.